Welcome to the second part of this CPD Bytes presentation on myelosuppression. My name is Nick Duncan, and I'm a consultant haematology pharmacist based at the Queen Elizabeth Hospital in Birmingham in the United Kingdom. In the first part, we introduced the topic and spent some time discussing neutropenia. What I would like to do next is focus on anemia and then thrombocytopenia. Anemia would be defined as a hemoglobin that falls below the reference range. And the usual hemoglobin reference range is shown on the slide. And as you see, it varies between men and women. Although I would emphasize that clinically significant anemia in cancer patients would not be expected to be seen until hemoglobin levels were quite a bit lower than these numbers. Anemia may be due to impaired production of red blood cells, for example, due to chemotherapy, but also related to nutritional deficiencies, and may also be related to loss of red blood cells in terms of bleeding or autoimmune destruction. And it is important to also be aware that cancer patients are at increased risk of anemia even before starting chemotherapy. In terms of classes of drugs that are associated with anemia, platinum analogues are especially prone to cause this effect due to their effects on EPO-producing cells in the kidneys. Common presenting symptoms of chemotherapy-induced anemia are presented here. Fatigue is undoubtedly the most common and is often multifactorial in cancer patients, but it is important to also be aware of these other potential symptoms, particularly symptoms such as shortness of breath and palpitations that would usually signify more severe anemia that may require more immediate intervention. In terms of how we manage anemia in cancer patients, we do not really have a preventative approach and would generally wait until our patients present with symptomatic anemia before intervening. Simple strategies involve patient education, as illustrated by the first bullet point. Red blood cell transfusions would generally be reserved for symptomatic patients with very low hemoglobin readings, and due to the potential problems shown on the slide, should not be offered routinely to patients with mild anemia. It is also important to check patients' iron stores, as well as their B12 and folate levels, as any deficiencies identified can generally be easily addressed with replacement therapies. The use of erythropoiesis stimulating agents, both short-acting and long-acting versions of the endogenous hormone erythropoietin, is controversial. As well as short-term toxicities such as hypertension and an increased risk of thrombosis, there is concern that they may have a detrimental effect on cancer outcomes. As you can see, there are both theoretical and real concerns that survival may be affected in certain clinical settings. And because of this, the FDA, which is the drug licensing body in the United States of America, does not recommend their use when chemotherapy is being given with curative intent. This slide also provides some data on the increased risk of venous thromboembolic events associated with this class of drugs. Finally, I would like to spend a few minutes talking about the management of thrombocytopenia in cancer patients. I have presented on the slide a standard reference range for platelets and also some classic presenting symptoms associated with low platelets, namely bruising and bleeding, a petechial rash, and headaches. Certain drug classes seem to be more likely to cause thrombocytopenia than others. For example, platinum analogues such as cisplatin and carboplatin, and also the proteasome inhibitor bortezomib. As you can see, the grade of thrombocytopenia is important, with milder forms generally only impacting on chemotherapy scheduling, but more severe forms putting patients at risk of bleeding-related complications. When we think about treatment options, there are three different strategies available to us, as presented on this slide. It is important to emphasize that unlike a red blood cell transfusion, which can provide benefit for a number of weeks, a platelet transfusion is only expected to provide a meaningful increment in platelet count for a matter of days. Because of this, there is increasing interest in using thrombopoietin receptor agonists, such as romiplostim and eltrombopag, to provide a more sustained benefit in terms of increasing platelet count. Currently, however, they are not considered a standard intervention due to issues in relation to cost, license status, and side effects. So, to summarize this presentation on myelosuppression, I hope that I have successfully conveyed the key message that myelosuppression is clinically important and remains a significant challenge in patients undergoing cancer treatments. As discussed, we have a number of preventative and treatment options available to us, but they are not suitable for all patients. Because of this, as pharmacists, we have key roles to play, both in patient monitoring and in advising on individualized and evidence-based clinical interventions. I hope that you have found this topic to be interesting and the presentation informative. I will leave you with some useful references if you want to delve more deeply into this important topic. Thank you for your attention.